And if we're just ready to take our seats for the rest of the morning lectures, please. Thank you. We're very lucky today to have Mathieu Spriet here, a professor at UC Davis. He obviously has reeled out a lot of PET scanners throughout America and has read an incredible amount of those images and has published a lot on the comparison of different imaging modalities in relation to racehorses. So we're very excited to hear his talk today. Thank you.
Thank you very much. Thanks for the opportunity of being here. I was here last 3 years ago. It was the last trip before COVID. I got home on an almost empty plane, not to get on a plane for another 2 years. So it's great to be back in here and see everybody. And I think a lot has happened in these 3 years, and I'm not talking COVID, I'm talking racehorses here. And I think definitely we've learned a lot in the last 3 years. We still don't have the answer to many things or anything. So I bring a lot more data than I had 3 years ago, but I think a lot of it is actually for discussion. And I'm very excited to present that to this audience because I'm sure we'll have some great discussion. So a bit more background. So as mentioned, I'm at UC Davis. I've been quite involved in PET research. I'm working pretty closely with Long Mile, with a company that develops a PET scan, but I do not have any financial interest there. I'm also working with Racing Victoria as a member of the Veterinary Imaging Specialist Panel, and I'm consulting for Santa Anita, Golden Gate Fields, and Churchill Down. So these are all my biases. What I'm planning on doing today is to review the role of diagnostic imaging for early musculoskeletal pathology. So I'll go over all the different imaging modalities. I think Pete has done a great job already showing a lot of that, but I'll just make a few more comments on that, and then probably spend a bit more time on advanced imaging and see where exactly we stand with MRI, CT, and PET. And as I've preloaded with my background, I'll probably spend more time talking PET than CT MRI, and then really open it on, it's mostly going to be a discussion, but I'll just throw some idea out there for discussion about what's going to be the role of imaging, because we've seen it change from being strictly diagnostics to moving on to monitoring, clearance to race, and potentially screening. And so all interesting concepts to discuss together. I wanted to start with acknowledging the imminent role of pathology behind everything we learn from imaging. And I got some of this imaging from Dr. Stover, and I think in California, all the job done by the Orthopedic Research Lab has been really important in building the path to what we are able to accomplish today with imaging, because everything we diagnose has to be related based on pathology. And so we'll be talking a lot about Condyle and Condylar Fracture, and so some example of growth section here and electron microscopy. And so all this past work is really important for us to know what we're looking for. And I think that's really the key with imaging. If you're just looking at an image and you don't know what you're looking for, you're not going to find it. And really knowing what we're looking for. And so that's why this work has been really important. And some more recent work, we'll talk a lot about Sesamoid Fracture, because this is one of the main focus in California, with many fatalities related to Sesamoid Fracture. And so that work has been really, really important. And so we'll start with radiography. This is the first tool we've had for over 100 years, actually. And as mentioned by Pete, it remains the most available, the least expensive, the quickest, and so it remains the first-line imaging tool. The limitations are we're just looking in 2 dimensions, so that leads to limited sensitivity, and that's also a modality where the interpretation of findings can lead to low agreement. But some example of multiple DP view, as Pete discussed earlier, and the importance of that, as on that regular DP you cannot recognize the pathology, but here you can see on this different view, you can appreciate it best here, that condylar fracture that you can see on that flex DP. So yes, radiographs allow, and I think what Pete mentioned earlier, rule in versus rule out is very important. And I think radiographs are really a great tool because they can rule in, in this case, we confirm there is a fracture, but they cannot be used to really rule out. And so that's where we'll mention the importance of other imaging when we cannot rule out things. For sesamoid fracture, it is much more challenging with radiograph, but there are a few cases like this one. And again, it's very important to get all the views you need. But when you look at this image here, bottom left, we can see multiple little lucency back here, and these are going to be vascular channels. These are things that we see very commonly, but it's important to recognize that this one coming horizontal down here, let me see if I can improve on the pointer. Here we go. Hopefully that's easier to see. So we have that lucent line here, which is an early sign of medial sesamoid fracture. So this is one case where we could confirm radiographically that there was some pathology there. And this is actually something that was confirmed. I had to bring a PET image early on. So this is a confirmation of the sesamoid fracture on a PET image on that same case. But this is one of the exceptions where we actually see the sesamoid fracture on the radiograph, but a good example that radiographs remain quite helpful, ruling in some pathology in some cases. Humeral stress fracture, more challenging because we're further up the limb, and this might be something like harder to achieve in the bone, but this is something that in the hospital setting with a high-frequency generator, we were able to recognize the callus here on the humerus, so we can also recognize stress fracture of the humerus radiographically. Ultrasound, so this is going to be the first line, soft tissue imaging, widely available, can be done stall side and fairly quick, with some limitation, some preparation and clipping, but I guess the biggest limitation is going to be that it is operator dependent and limited information for bone, but actually I'll show one example of that. So this is classic superficial flexor tendon, pretty big injury, so pretty straightforward, but again, this is one of the beauty of ultrasound, being able to easily confirm and monitor this type of injuries. As we're talking about more subtle changes, suspensory branch, where here we'll see some changes in the fiber pattern, so catching a more subtle change in the soft tissue here with ultrasound. And so again, flexor tendon, suspensory are going to be where we use the ultrasound most commonly. But I was mentioning the limited use for bone, but there are actually some application, and this is a humeral stress fracture as I was seen on ultrasound. So we should have nice smooth bone contour here, and actually this is from that same case on which we had the radiographs on, and so to help orient that image, so that ultrasound image is in that square here, and showing, because technically that radiographic image, as I was mentioning, is going to be hard to obtain just in the bone, but this is something that you can do with in the hospital. But if you're in the bone, potentially just with the ultrasound equipment, you'll be able to catch that callus at the back of the humerus. Again, it's going to be more of a rule in than rule out. It's not because you're not going to see it with ultrasound that it is not there, but in some cases, ultrasound can help rule in some humeral stress fracture. So speaking of stress fractures, the next modality that is going to be like the gold standard is going to be scintigraphy, with the advantages of being really highly sensitive for bone stress remodeling. The potential with scintigraphy to do whole body imaging. It is readily available, ranked it as moderately expensive. So the limitation are going to be the radiation rules in place, depending on country rules, the access to the radio tracer, how long you need to keep the horses. But this definitely has helped a lot. So some example of Fetlock scintigraphy with the need to do a bit of creativity with getting like some Palmar views here, some flex lateral views, so a bit of work here. I think where scintigraphy has made the biggest difference when it was introduced was really recognizing this humeral stress fracture. And I've mentioned some ways of, yes, we can potentially see stress fracture with radiographs and ultrasound, but definitely the gold standard, the most sensitive, is going to be scintigraphy, with here a nice example of a caudal humeral stress fracture and example of a tibial stress fracture here. So this is definitely going to be the go-to for that. So I think this covers what we have had for many years. And I think the question about advanced imaging has been around more recently, and can we do more than what we've done with this re-imaging modality? And definitely, and I'll start with MRI because of the three modality we'll discuss, MRI, CT, and PET. I would say, interestingly, MRI has been around, and there's more data on MRIs than on CT, which might seem counterintuitive because CT has been around in human medicine for longer, but I think a lot of that, we'll just make a little shout out to Hallmark, because Hallmark early 2000 has designed these systems that can be used on the standing horse, and this really has been a game changer in lameness evaluation, with the ability of looking both at soft tissue and bone. And here I'll introduce the concept of structural and functional information. When we're talking radiographs, when we're talking ultrasound, we're talking a lot about looking at the size and shape and density of structures, but we have very little information of what is actually happening at the functional level. Is there some activity? Is there some turnover? Is there some increased fluid? And so MRI really brought that concept because we were looking at bones, mostly looking at size and shape, and with MRIs, then we have that information. Is there some inflammation in the bone? Is there some fluid in the bone? And this really has been a game changer. The limitation with MRI are the longer acquisition time. Typically, if we want to image one fetlock, it's going to be 30 to 45 minutes to an hour. It is more expensive, and I wrote limited availability. I actually used that slide first in the US, and I would say that in the UK, we have actually more access to standing MRI for racehorse practice than in the US. And I think Fetlock MRI in the racehorse really started here too, so big shout out to Sarah Powell with that first study like in 2012, so over 10 years ago. And so I think this is showing how much data we've been able to accumulate there in 10 years. And so this is definitely, of all the advanced modalities, the one that has been used the most in racehorses, with a lot of work down here in Newmarket. And I think this is a figure from Sarah's paper showing all the different information you can get from an MRI. And so we see that little like bright signal on these like different sequences showing that there's a crack in the bone, but then that larger white area here is looking at a sequence showing us fluid. And so we know there's a lot of remodeling in this condyle with this little defect and a lot of fluid. So we're really gaining a lot of information we did not have access to before. And so there's a few other study on MRI. This one is from Florida with John Perozzo, where he did quite some work with characterizing the Palmar condyle, Palmar osteochondral disease, looking at different pattern of changes there. And back to some work from the UK here. And so this was like some post-mortem work, but really important work investigating the potential help from MRI in looking at Condylar fracture. And some very interesting observation here, looking at the sclerosis in the condyles, that will be that dark area on this MR image. And you can appreciate some difference here on that medial condyle. We have something that is round, that is centered over the condyle, when here we have something triangular that comes further axial over the groove. And he was recognizing that study that that type of sclerosis coming over the groove is associated with a condylar fracture. So that's a very important observation that we use a lot in fracture risk assessment, being the severity, the size, and location of the sclerosis. And another study here back in Florida, again, looking at also the presence of fluid signal associated with fracture. So through this study, we learned the importance of looking at the extent, shape, size of the sclerosis and the presence of fluid. And so here is a clinical example I was involved with showing that what was described in that study, with that sclerosis extending over that groove, and with some fluid signal we can see on the fluid sensitive sequences. So here evidence of an early condylar fracture recognized with MRI. There was some work looking at the Sesamoid too, and what was shown is that there is a sclerosis of the Sesamoid that is associated with fracture. I think the challenge here is that sclerosis is going to be extremely common in MRI in the sesamoid, so it's limited value for fracture risk assessment because it is very common. A case I got here actually as a courtesy of Chris Rigg a few years back actually. We were discussing that with Dr. Stover. And so Chris shared that case with us as we have this focal hyperintense signal in that medial sesamoid because it was at the time that Dr. Stover's lab had published this paper showing that there was focal osteopenia, focal bone remodeling associated with medial sesamoid fracture. And this finding, I'm using that case from Chris a few years back because it's actually not very common that we can appreciate that on MRI, but this is a good example that we can recognize that on the MRI. And so that was a case considered high risk for fracture, again relating to the knowledge we have from pathology to help being able to interpret what this bright area means on the MRI. So moving on to CT, and so this is what has changed the most in the last 5-10 years, I would say. This started 10 years ago. I'll just use the word craziness. I think they will agree with that. This is an image from Penn, and this is a robotic CT they're using, and they've done an incredible job with that. It is definitely scary when you first see these giant robots moving around the horse, but yeah, they've been using it for 10 years, and there has been no major issue with that. So this is pretty impressive. Technically, you have an X-ray tube and a detector plate that rotate around here's the hind limb as they're scanning the hind fetlock. So that's one option for standing CT. Then this is Chris Whitten from Melbourne using that other CT system, which is the ASTO CT that's been developed in partnership with the team from Wisconsin. And completely different setup here, but so the concept of that gantry raising from the floor to image here's the hind fetlock on this horse. Couple other setup, a bit more recent. This is the Calibra system, been around for almost 5 years now, based in a company based in Germany that designed that. So the concept here is that they're using like a regular, classic fan beam CT, a large gantry, but that is built in a pit and that can move up and down and back and forth. And so instead of having to put the horse on the table and move the table through, the whole gantry moves. So the challenge in using it standing that the horse is non-weight bearing. So this brings some limitation, but in terms of imaging capacity, this is like high-end CT imaging. Back to the most recent one, the Hallmark system that is 2 or 3 years old now. And so most simple design with X-ray source and just like the detector plate here that will spin around the horse. So like smaller equipment here, but ability to image the foot and the fetlock on these guys. So yeah, quite a few options for CT. What are the advantages? So we're looking at cross-sectional imaging, so 3D imaging like MRI. We're using X-ray source, so it is pretty much 3D X-ray, so excellent bone detail, fast acquisition. One scan is going to take typically between 30 seconds and 1 minute. The limitation is that we're going to be looking at bone, but purely structural information. We're looking at size, shape, density. We don't know if there's some active changes going on in the bone or not. No functional information. The availability is more limited, but with all these different systems, it's definitely increasing. And this is moderately expensive, cheaper than MRI, but definitely more expensive than radiographs. I got this slide from Dr. Thoroughbred from Penn, showing a bit of the range of what they see with CT in the condyles, from some lateral condylar fracture, incomplete fracture, focal resorption in the groove, focal resorption in the condyle, the more classic like saucer shape of this like Palmar osteochondral lesion, some more lucency extending in the groove, fragmentation at the back. So there's really a whole range that you can see with CT, and with higher spatial resolution than MRI, a really good characterization of these different lesions that we can see. And this is a figure from a paper from Wisconsin with Peter Moore, when they were looking at some of these lucency in the parasagittal groove and doing some in vitro mechanical testing. They've confirmed that these lucency in the groove are predisposing to propagation of a complete condylar fracture. This is a more recent study from UPenn where they describe the appearance of condylar fracture on CT. And so what I like with this figure is that it shows the complexity of things as it comes to condylar fracture. The image on the left is a classic one that propagated straight from the parasagittal groove, likely from some underlying pathology, as we see that lucency at the Palmar aspect of the condyle. But then we see some condylar fractures that will come like further out on the condyle, extending here from likely from palmarochondral disease. And that's something that's fascinating. That's something we discussed a lot 3 years ago here. And I think there's different opinions on that. But I think more than different opinions, there's different population. And I think what we see in California is probably different from what you guys see in Newmarket or what Chris sees in Hong Kong. And these data are from the east coast of the US because it's from Penn. And so we definitely see quite some fractures that are coming through the POD lesion, which makes it more challenging in terms of fracture risk assessment. But I'll hopefully get back to that with some PET work we've done in that area. This is another example from Penn, sorry, showing that incomplete condylar fracture. And what I like about this case, I was mentioning the MRI paper talking about the sclerosis, the shape, and I think what we learned from MRI applies to CT here, when we can see that sclerosis that is centered over the groove and that lucency right there, so confirming that the shape of sclerosis is going to be an indication of what's happening there. Here's another example I have from Florida this time, from John Madison over there doing a lot of work with the Calibra CT. And so this is a case I discussed with John because a really interesting one is like, what do we make of this one? Is this like POD? Is this a fracture starting to go through a POD? Depending on how you look at it, it can be a bit like, if you just look at that sagittal view, this looks like a classic POD, but then you can see that there's this lucent line, and so it's likely that we have an early fracture through a POD lesion at this site, so showing the complexity with that. And comment about the sesamoid bones, a bit the same as with MRI. We can see some changes, and here another case from Penn, where there is definitely increased sclerosis in that actually lateral sesamoid here compared with the medial. You can see that it's much more dense bone. And then when we look on the sagittal, actually you can appreciate like a mild lucency at this level. So showing that we can appreciate some changes here on the CT. So with that, I'll moving on to PET. And so I've started being involved with PET. We imaged the first horse in 2015. He was under general anesthesia at the time, but did quite some exciting exploratory work under GA, and based on that work and based on some funding coming from the Stronach Group, Santa Anita Park, Southern California Equine Foundation, we were able, working with Longmire, to develop in 2019 the standing PET. And so this is the first racehorse image with standing PET at Santa Anita, now just over 3 years ago. And we've done quite a bit with that, so I'll focus on that. Now, so what is PET and what are the advantages? So this is nuclear medicine. So like scintigraphy, we're going to inject a radiotracer, let the radiotracer distribute, and then acquire the images. But the advantage compared with scintigraphy is that this is cross-sectional imaging. So I was mentioning CT being like 3D radiograph. I can say the same with PET. PET is 3D bone scans, 3D scintigraphy. And so this is purely functional, because we're not getting any indication about size and shape of structure. We're getting indication of distribution of the radiotracer. So what happened is that there are some area in the bones that are going to have increased blood flow, increased bone turnover, and this is where this radiotracer is going to accumulate. So like we mentioned, bone scan being super sensitive to recognize humeral stress fracture, tibial stress fracture, because they catch these early changes, early bone turnover. So PET will do the same thing, but in 3 dimensions. Acquisition is fast compared with MRI. Just talking MRI, 30-40 minutes per joint. Here we're talking 3 to 4 minutes. So slower than obviously radiograph or CT, but much faster than MRI. So the limitations, no structural information. This is why in many cases we'll like to couple it with a CT, for example. Same as scintigraphy, we have radiation safety rules in place. Advantage of PET, when we're talking nuclear medicine, we're talking half-life, which is how long the radioactivity is going to be there. Advantage of PET is that the half-life is only 2 hours compared with 6 hours for bone scan. So with bone scan, and again, from a country to another, it's going to be different. But in California, bone scan, we have to keep the patient for 24 hours after injection. With PET scan, because the radioactivity disappears faster, we can clear the patient and sending back to their bone within 6 hours after injection. Limited but increasing availability. Technically limited to the US at the moment. First international installation will be in Melbourne in September. Hopefully coming to Europe in the next few years, and moderately expensive, similar to the cost of a CT scan. So this is the PET scanner. So openable ring of detector. The reason we went under general anesthesia initially, we were using like human equipment, which is a fixed ring, and didn't want to have a 25 centimeter fixed ring around the horse distal limb, but work with the company and develop that system that opens up and goes from floor level to something like 60 centimeters up. So from foot to carpus, foot to tarsus on the hind, 3 to 5 minutes per site. So this is the first, some early data on PET showing what we're looking at. We're looking at bone scan in 3D. And so the color scheme that is used here is like hot iron. So if you think about the high run being the hottest, turning yellow, and so that's what you see here. So normal bone is going to show up red, and so this is normal bone on the left, and on the right we have a racehorse with increased uptake in the Palmar condyle in the apex of the sesamoid. And so that's part of our original study, and so we got to do some pathology work to validate that initially. And so what's really interesting to see here is so that same horse, that bright yellow spot, what does it look like in gross section? This is what we're looking at. And so what's really interesting is that there is a pretty clear lesion here. We got that bright yellow spot that everybody will recognize. But what's happening in the bone at that level, there's no structural defect. There's no actual defect in the bone. We can see intact cartilage. We can see intact compact subchondral bone. But there's a big bone bruise here. If we look at the microscopic level here with MicroCT, we can see increased porosity. And then the histo is showing that this increased porosity corresponds to small blood vessel and increased bone activity. And so that's what's happening when we have a hot spot. It means there's increased blood flow and there's increased bone turnover. This is what we show here on this image. And so when we studied at the racetrack, and so again, that's December 2019, Santa Anita, and we were, curious what we would see. Are all the racehorses going to look the same? Are we going to see a range of different things? And this is a very busy slide, but this is on purpose to illustrate the range of findings we see. And obviously, the most common finding are going to be increased uptake in the Palmar condyle, like we see here. But again, especially in California, Hong Kong, Australia have similar issues. It sounds like here you have less issue with the sesamoid, but increased uptake in the sesamoid is something we see pretty commonly with 3 different examples here at the bottom. Some dorsal P1 uptake on this one, so quite a range of different things. And so I looked at that, and so this is data from the first year of PET scan at Santa Anita. So in the first year, we did 187 Fetlock. And I actually like this one because it illustrates all the categories we had defined with uptake in the Palmar condyle, uptake in the sesamoid, uptake in proximal P1, uptake in dorsal MC3. But when we look at the distribution, what did we see? Medial Palmar condyle, not surprisingly, is the most severely affected. And these are graded by severity, and I'll explain the grading more a bit later. But so we have over half of the horses we scanned, and so all these horses were scanned for diagnostic reasons. So they had some fetlock-related issue. Over half of them had some change in the medial palmar condyle, lateral palmar condyle a bit less frequent, and then the medial sesamoid bone. Again, on these California horses, 25% of horses having some issue in the medial sesamoid bone. P1, much less common for us, distinguishing the dorsal-proximal P1, potentially little chip, from the subchondral bone of P1. And subchondral bone of P1, which is something we catch a lot with PET in sport horses, but much less, at least in the California population. So this is what we saw on the front. What's interesting is this is what we got on the hind. The numbers are much lower. We scan much more front than hind, but really interesting to see the complete different distribution. The lateral condyle much more commonly affected than the medial condyle. I would use caution in because like the percentage are technically higher, but I think it's more likely that if we scan the hind, it's definitely that there are some concern on the hind. So I think there's a bit of a bias that we end up scanning the hind fetlock when there's more severe pathology than the front. So I don't think it would be true to say that there's more lateral condyle, hind lateral condyle than front medial condyle pathology. I think it's a bit of a bias. But what's interesting here is to look at the distribution and recognizing that medial versus lateral is clearly flipped in the hind versus the front, and this is true both for the condyle and for the sesamoid bones. Speaking of sesamoid, one thing that's very interesting with PET is that as we have this 3D information, we can really characterize where the changes are coming from, where the uptake is coming from. And here's 3 different examples with this dorsal mid-body area on the top row. And these are going to be the most common changes we see, especially in the medial sesamoid. So this is an example here. This one obviously has both medial and lateral, so dorsal mid-body, and this is the one we're the most concerned about. As you can see on this one, starting going linear, this is definitely something we're concerned about fracture. Then we have some uptake in the abaxial area, which is going to be more likely to be related to the suspensory ligament, and then focal uptake on the apex, which is not as common, but which is more related to degenerative changes. So back to that dorsal medial focal uptake. Here is a pretty spectacular example of one of them. And what's very interesting here, and the more I look at PET, the more I learn from that, there's looking at the lesion, and it's really important to recognize that hot spot, but it's also going to be super important to look at the rest. And I mentioned it's very common to have some medial condyle uptake, and we can see that this one has very little condyle uptake, which makes me think that makes this lesion even more of an issue, and we'll get back to that, as I mentioned, scanning normal horses. And you know what's fascinating, and I was mentioning the importance of all the pathology work, and actually 2020 was when we started recognizing a bunch of this, and it's at the same time that, you know, unrelated, but really interesting because we could, at the end of the day, relate them together, independently, should I say, actually. So Orthopedic Research Lab put out that paper at the same time as we were starting seeing that, and I remember sitting with Sustova and be like, okay, we're talking about the same thing, and which is really something fascinating because I think there's been a lot of work on the past side and being like, oh, we see all these changes, we know there are these pre-existing changes, but the challenge is to catch them in a non-invasive way in horses before, you know, they progress to something more severe. And I think this is a great example that we've been able to achieve that with PET at that level. And we're discussing that, and I was talking with Tim. It's always like fascinating and scary to listen to Tim talk because it's very important, all this, all the data, but like how much, you know, can we make of it? And we were discussing of that, about finding that threshold on the stats. And I was mentioning that early on, when we started to see sesamoid light up, we were like, okay, we're going to be super careful. But now, as we've seen more and more, I kind of refined a bit the threshold of what I'm comfortable with. And so I was talking with Tim. I really remember, like, you know, from all the data he has, we have to make this decision. We know that we're never going to be as good as the model that say, let it run is going to be safe. But we know that that model is mathematically great, but we have too many horses dying. But we have to accept the fact that to prevent one horse death, we're going to have to stop more horses than one from racing. And so what really my approach is to this risk assessment, and knowing that, you know, technically the model needs more validation. We were discussing that last night at dinner too. Like, ideally, we should just like scan them all, let them run all, and in a couple of years crush all the data, but this is not something we can do from a human standpoint, and a logistic standpoint too, let's be honest. But so when I see something like that, to me, this is probably the worst. I mean, there's always one, this is the worst from a year ago. I've probably seen one worse since then. But when you see something like that, this is really like impending medial sesamoid fracture, and we have to stop this horse from racing. How am I doing with time? I still have a lot of things I want to talk about. Well, I'll just go briefly on this one. Scintigraphy, you know, we can tell that there's some increased uptake in the Condyle, but scintigraphy did not catch the sesamoid. That PET did catch pretty well. This slide I got from my colleagues and friends from Penn too. Like, really cool correlation between what we can see on the PET and on the CT. So this is classic CT incomplete condylar fracture, and this is what it looks like on the PET. So you can see that the uptake is really matching the extent of the lucency. And so it's really good. Like, the combination of the two modalities is really advantageous because on the CT we see that, and there's always a question, like Pete illustrated very well with radiographs, and with CT potentially we have the same concept. It's just like, you know, what is chronic changes versus what is active. And so here the PET is telling us there's something active there, and the CT is showing us, yes, this is indeed a fissure or an early fracture. And so we have really all the information when we combine them. One advantage with PET that I mentioned is the ability to grade. And so what you can do, you can get some measurements, probably too small to read on that screen, but we can use this region of interest, and we can tell that we have the activity in the lesion versus the activity in the background. And so we've been using that to grade the severity, and this has been quite helpful for follow-up. And so we had a study where we had 25 horses that we scanned and rechecked the scan at 6 weeks and 12 weeks. Forgot to include the reference, but if you're interested, this is now published in JAVMA last year with Pai as the first author. And this is the original scan. What it looks like at 6 weeks, very interesting in terms of pathophysiology. We've had a few of these cases that at 6 weeks almost looks worse, especially that P1 lesion, you see it here, it gets worse at 6 weeks. And it does make sense that as you take the horse off training, sometimes the remodeling is going to accelerate a bit. And so it's very interesting. We've had a few being like worse on the scan at 6 weeks, but then improve at 12 weeks. And I like this case because it illustrates how the P1 first got worse, but then was pretty much clean at 12 weeks. When the dorsal lesion hasn't changed that much, the Palmar condyle lesion did improve quite a bit, and the sesamoid lesion still needs more time. And so this study was really helpful in exploring all that, you know, validating the repeatability of the technique and looking more into the grading system. I came up with that weird graph here, so I'll explain it a bit. Because this is using the same hot iron scale pretty much. So the dark red is going to be normal bone, the bright yellow is going to be the worst one. And so this bright red is going to be grade 1 with like lesion to background between 1 and 2. This orange is a grade 2 between 2 and 3. And here lesion to background more than 3. And what I was looking at here, this is a distribution of the grade on the initial scan and how they did after 6 weeks and after 12 weeks. And what we showed that there was an association between the severity of the grade and the speed at which this lesion heal. And so if you look at 12 weeks, 71% of the grade 1 were back to normal, 40% of the grade 2, but only 22% of the grade 3. So this is based on 25 horses, so this is not as much data as Tim has, but this is a start. And this really helps us now when we diagnose a lesion to try and decide how much time we expect this horse to need off and when we should consider rechecking. So after we did that, we were interested in looking into what happens when we get these horses back in training. 5 minutes, okay. And looking into that was quite helpful with some successful story like this one. Original scan, he got 3 months off, back in training in August, was good. In December, still good, and this horse is racing and doing great. An example here that didn't do so well. Initially, we had that sesamoid lesion we were worried about. It was clean at the beginning of training, but then in December, pattern has returned to what it was originally, which is something we learned from these studies. These horses that were stopped for a reason, had a scan, go back into training, most often when they were failing for the same thing, and this was recurrence of the same lesion that would typically occur at peak training when they reach 4 to 6 months. Here's an example of a pretty severe one with like a sesamoid we were quite worried about, but this one got quite some time off, got 5 months off, but then went back to racing, and we see that these scans are not perfect, but at least what's good is that we have some uptake in the Condyle, but not that much in the sesamoid, and this horse kept racing for a while. I want to show, I'll have to skip on that one. Yeah, let's move on to this normal horse study, because that's something quite important we did, and it was multi-center between Santa Anita, Golden Gate, and Fairhill. So we randomly, ahead of the weekend of racing, we're pulling the horse finishing second in the third race will be invited to take part of the study. And we only pulled top 3 finisher, and horses had to be looked at and make sure that they were sound after the race. And what was interesting is out of these 72 horses that were performing well and technically sound, this is one of them. And so actually one of them had an incomplete condylar fracture that had not been picked on clinical exam. So we had about 3 out of 72, so 4% that were actually laid up based on PET findings, and about 20% for which the training was backed up a bit based on the PET finding. And when we look at the distribution, that was very interesting too. So this is the data from Santa Anita. Again, we have 3 centers. And so we were, so this is a graph I showed you earlier, or a similar graph with just like a more limited population here, and showing that the normal horses tend to show a similar distribution, but obviously much less findings. And what's really interesting is that, again, more medial than lateral, but actually much less lateral, or the lateral at a lower grade, which is something I want to comment on with the next work we've done, which was looking at condylar fracture, working with Ryan Carpenter at Santa Anita. We had 14 horses on which we did PET 48 hours after fracture repair, and a couple different things. Here's an example of a classic fracture in a sagittal groove, and you see the kind of uptake here, but you can see pretty narrow uptake down in that groove, versus another case with a fracture occurring further out on the condyle, and you can see actually the maximal uptake up here where it broke through the cortex, but when you look distally, instead of having this kind of narrow uptake, you have this more like round uptake, so suggesting that here we likely had some Palmar osteochondral disease going on. And the one thing I've been really interested in looking at in this population is look at the contralateral limb, but also look at the contralateral condyle. And so this is the one that fractures through that lateral groove, and we see no uptake at all in the medial condyle. When we look at the other fetlock, it has a little bit of uptake in the lateral groove, but some uptake in the medial condyle. And I think we've done a lot of work, you know, being CT or MRI or imaging in general, looking specifically at this lateral condyle, what is the shape of the lesion, what is it that we see here? But what I've noticed through this PET study, for me, it's super interesting to look at the medial condyle, and if the medial condyle doesn't light up at all, I tend to think that this horse is not loading properly and more at risk of fracture. I'm being told I need to get out, so I'll wrap up quickly with the indication for imaging, as I mentioned early on. You know, investigation of lameness, monitoring of healing, monitoring for recurrence, and then clearance to race or screening. And so, you know, this monitoring, I've shown some examples depending on the severity of the lesion. We can do different time points, monitoring for recurrence. Key thing is at peak training. Here, clearance to race is something really interesting, because we mentioned we scan all these normal horses, we stop 3 of them, but it's 5%. From a logistics standpoint, it's difficult to consider that this would be feasible, but this is where potentially imaging has a controversial role into helping to decide on clearance to race, but I think it definitely has a role there. Horses flagged for gait abnormalities, and you know, it is very subjective, the one gait abnormalities, and I think having some more objective data in a regulatory setup is going to be potentially pertinent. Horses coming off vet list, making sure they're clean to run again, horses resuming training, or other pre-screening tool being if through the data that Tim has, a horse is spotted at risk, getting some more information here. I think we've mentioned the challenge of you know, these events being so rare, and so I think potentially gaining more data and looking at it from different perspectives can help try to have the best results. And then the question of screening for fracture risk assessment, different ways of doing it. One of them is just prior to a big event with the example of the Melbourne Cup. Another option, which is interesting, is to have longitudinal follow-up, which has more advantages, and pretty much what Pete is describing doing clinically. If we can do that with imaging, it really helps knowing which horses are at risk and when do they need to be scanned more and when can they race or not. I'll just finish quickly with some acknowledgement, because there's been a lot of work that's been done and would not have been possible without a lot of funding from Grayson Jockey Club, Southern California Equine Foundation, Pennsylvania Horse Racing, all the racing partner I got to work with, Santa Anita, Golden Gate, Racing Victoria, Fairhill on the East Coast, and work done with UC Davis, Penn Vet, and Longmire that put the pet together. We'll have some questions later. You can email me some question, and you can follow me on Twitter for some updates on the research. Thank you. Sorry for the overtime.
Thank you very much, Mathieu. That was really great to see that PET scanner and